Friday briefing. This week, we're looking at the long-term effects of COVID. The total number of confirmed cases of COVID-19 in the UK passed 3.7 million this week. And it's estimated that between 5 and 10% of those people will go on to develop the condition known as long COVID. So that means that between 180,000 and 370,000 people could end up suffering from long-term health conditions, from fatigue to serious organ damage. The implications of this are huge, but how much do we know about this condition and what can be done to treat it? Independent Sage has just released its new report on long COVID, and today we're joined by two guest experts who will be helping us to address this important subject. Dr. Sarah Elkin is a consultant in respiratory medicine, and she's the clinical director of integrated care at Imperial College NHS Trust. She's also been one of the leads setting up the post-COVID assessment clinics across London. We're also joined by Dr. Nisreen Alwan, who is Associate Professor in Public Health at the University of Southampton and Honorary Consultant in Public Health at University Hospital Southampton. Dr. Alwan has personal experience of long COVID and has been one of the UK's leading advocates for greater awareness and further investigation into the condition. So we will be focusing on long COVID in our discussion today. But first of all, as usual, we'll start off with the latest facts and figures and objective analysis from Professor Christina Pargle. Over to you, Christina.
Right. So hi, everybody. Welcome to today's briefing. So it's mainly good news this week. So that's nice. So we're talking cases, hospitalizations, deaths, and then vaccination data. And the first thing before we actually look at case numbers is just from NHS Test and Trace report, we can see this is the timeliness of getting your test result back. So getting your test result back really within a day of taking the test, that has shot up this month. So we're back at 70% of results got quickly. And that's really important and good news. The number of confirmed cases across the UK has also been coming down pretty steadily since it peaked at near the start of January. And this is true for all the nations in the UK. And if you look at positivity rate, which is the percentage of people who had a test who then test positive, and this is using PCR tests, you see the same thing. So you can see, a big peak in beginning of January, and then it's been coming down pretty steeply ever since then. However, the ONS infection survey, which released today, paints a slightly different picture. So for instance, this is the estimate for Wales, and you can see that since kind of the end of December, it's been pretty flat in Wales. So this is the number of people who test positive, and this is a random sample of people. It's not quite the same kind of thing as the dashboard data, which is kind of new infections, but you'd hope that they show the same pattern. And they certainly show the same pattern on the way up. So this is a little concerning. ONS said the same thing for kind of Scotland and Northern Ireland. And if we look at the English data using ONS and REACT, which is a really big study out of Imperial, where they test 170,000 people across the population every month, that's the turquoise dots. You can see that they match, and they've not seen a really big fall since December. So this is showing something that's a bit different from what we're seeing on the government dashboard. If we look at English regions, this is from Public Health England. So the Public Health England report came out yesterday. They have positivity rate, percentage of people who test positive across the different regions, and they show it going down pretty steeply in all the English regions. If you look at the dashboard positivity rates, it's a slightly different thing. So Public Health England is only community tests, so what's called Pillar 2. The dashboard combines those tests with the hospital tests, but they show a much slower decline in positivity than the Public Health England results. And if you look at the ONS infection survey, again, that shows something different again, where actually for ONS, the only places that are really going down are London here and the northeast here, and everywhere else is kind of flat. And that's also a bit similar to what React showed. So what we're seeing now is that we've got 4 different sources of data, and they're all showing us a slightly different picture of what's happening. So I think, we definitely have peaked. We're not going up anymore. We just don't really know quite how fast we are coming down. This might be one possible explanation. So this is from the ONS infection survey, where they look at the new variant, which is this dark blue line, cases that are compatible with the new variant. They look at the old variant, kind of this COVID we had over the summer and autumn, which is this green line. And then there's this turquoise line, which they say they can't tell. But in the kind of description, it thinks that the turquoise line is people who might have had COVID for a while. And so we don't know if they're still infectious, but that's why they can't tell which variant it is. And what you can see is that the old variant is going down everywhere, particularly in Wales. The new variant is coming down, but more slowly, which is kind of makes sense if it is more infectious. And this kind of turquoise line is going up, and that could be a kind of a hangover from the big peak we had in January. It could be, if it was the new variant, that maybe people are infectious, test positive for longer. I don't know, but this could explain the difference between ONS and the cases. So we'll see what happens next week, when this should start falling, if that is what's going on. Looking at hospitalizations, this is the number of people in hospital per million people across the UK nations. It's coming down pretty steeply in Northern Ireland. It's coming down in Wales and England. It's kind of stopped growing in Scotland. So that is a good thing. It means that we should now be starting to relieve pressure from the NHS, but these numbers are still really, really high. We're still above the April peak in every nation. Admissions are now coming down. This just shows the 2 lockdown periods in England. This is English data. And they are now coming down from this really high peak a couple of weeks ago. So that is also good news. And it shows, I think, that the new infections are coming down in the country. And that's true across all the English regions. And you can see that the regions that were in tier 4 before January, so London, the southeast and the east of England, started coming down earlier, which makes sense because they've had kind of harsh restrictions for much longer. And just finally on hospitalizations, this is the number of people in intensive care beds. Now, intensive care is kind of the last stage of your journey in hospital. And so it just takes much, much longer for lockdown to have an impact on it. But we have just reached the peak. It looks like that's now coming down. But what you can see is that we've got a really, really long way to go, not just even to get down to the peak we were in April, but to get anywhere near where we were in November even. So the NHS is going to be under some pressure for several weeks to come. Looking at deaths, this is the number of weekly death registrations from COVID registered per week to the 15th of January. You can see, unfortunately, that has really leapt up over January. Some of this is reporting delay over Christmas. It's not sadly surprising given the number of cases and hospitalizations we've had over the last month. So this is now up to 15th of January, well over 100,000 deaths involving COVID-19. And 88% of those have COVID-19 as the main cause. People are dying from COVID. And in the week to the 15th of January, almost half of deaths in England involved COVID-19, England and Wales. Looking at the number of deaths within 28 days of a positive test reported, which is the most recent measure that we have, it looks like we have just reached the peak. We got some really high numbers last week and this week, but hopefully now these will start coming down, and with the impact of vaccination, hopefully we will never get close to this again. And we're now at 103,000 total deaths reported within 28 days, and that's 29,614 since the 1st of January this year. And what that means is that well over a quarter of all deaths in the UK have been reported in the last 4 weeks. And I just wanted to highlight that because it just shows quite how devastating this second wave has been. But some better news now, vaccination data. Almost 7.5 million people have received their first dose of the vaccine in the UK. And this is daily vaccination rates. Blue is first dose, orange is second dose. So we can see we're doing almost only first doses now. It has dropped a bit over the last few days compared to the week before, but we're still vaccinating, almost 300,000 people every day, which is good news. And this is just the population coverage by nation over time. So, between 8.5% to 11.5% of each nation has now been vaccinated. Again, this is really good news, and hopefully this will keep going up rapidly. This just shows you, in terms of the over 80s, this is from NHS England data. They publish regional breakdowns for the vaccinations, and you can see that a high proportion, that's these orange bars, of over 80s have been vaccinated in every region. Almost 90% of over 80s in northeastern Yorkshire have been vaccinated. London is trailing with only 65% vaccinated, but that's still a high proportion of over 80s, and that should start having quite a big impact on deaths in February. One issue, however, is it's not equal who is taking up the vaccine. So there was an Open Safely study published this week, which looked at GP records of millions of people. And that showed that 42% of white people offered the vaccine are getting it, compared to much, much lower rates for people of South Asian descent and Black British people. And there's the same kind of disparity for deprived neighborhoods compared to the least deprived neighborhoods. And that is really concerning, not least because we know that people in those communities are more exposed to getting COVID and more likely to get sick if they do get COVID. And so this is something that we really have to address with communities to try and increase the proportion of people taking up the vaccine. And this is just to show you again, I showed this plot a couple of weeks ago, that the vaccine will have a big impact on admissions and deaths, but it will not have a big impact on confirmed cases. There will still be a lot of people who will be out there getting COVID if we relax too soon. And that has implications for long COVID as well. So as Alice said, since March, almost 4 million confirmed cases in the UK, but we know that it's really much higher than that. We've had 100,000 deaths. So from that, at least 10 million people will have had COVID in the UK. And there will be hundreds of thousands of people in the UK living with long COVID now. So just to summarize, case numbers and hospital admissions are falling everywhere, which is good. Deaths look to have just peaked. Also good news, but peaked at a really high level. ONS and REACT, the kind of studies that are kind of looking at a random sample of people and testing them, are painting a slightly different picture of where we are. So, I would say that we know things are getting better, but we don't know quite how quickly they're getting better because there is just this discrepancy. Over 1 million people have now had their first dose of vaccine by the 3rd of January. And the reason I raise that is because they are now 3 weeks out of that first dose. And so I'm assuming that the government is very carefully, or Public Health England are very carefully tracking the outcomes of people who are now more than 3 weeks from their first dose of vaccine and seeing, how long is protection lasting? Is it still lasting? And I'm hoping that at some point that data will be made public and that we see how effective the vaccines are after 3 weeks, and they break that down by age and demographic data. And finally, just, the high infection rates that we have now, the high burden of COVID that we've experienced in the UK means that hundreds of thousands of people are living with long COVID now and are at risk from developing it in the future. So, death and hospitalizations are not the only metrics we should care about. There is no dashboard measure for the number of people with long COVID. Maybe there should be, but I'm hoping that in this session we can answer some of those questions. And that's it from me.
Thank you very much, Christina. Now it's time for Professor Martin McKee to say a few words about that new report on long COVID before we hand over to our guest experts this lunchtime. Over to you, Martin.
Thank you very much indeed. So I think Christina has already picked up one of the most important points, is that if we only focus on the number of cases and the number of deaths, we're missing out the problem of the people who will be left with the problem of long COVID. What we do in our report is to briefly describe some of the characteristics of what we know about this condition, We do know that this is a condition that can affect very many different organs in the body, because the ACE2 receptors that the virus binds onto are dispersed quite widely across the body. And in addition, the immediate impact of COVID with blood clotting and damage to individual cells is considerable. That said, we're still learning an awful lot about this condition. Our knowledge is evolving quite rapidly, but there are things that we can say already, which are recommendations for health policymakers, and we set them out in our report. So essentially, we need much better data. Christina has already pointed that out. We need to have some sort of a register of people going forward. Building on the work of the post-hospital study, which my colleague Kamlesh Kunti, who's one of our members in Independent Sage, is a co-investigator on. They're following up 10,000 people who've been in hospital, looking at the course of their condition going forward. Although it's important also to recognize that people can get long COVID who have never been in hospital. And in fact, there are many people who've got long COVID who were never actually tested for COVID at the early part of the pandemic, when testing was rather limited. There's still quite a way to go to make sure that all health professionals are aware of this condition, and in particular to make sure that they know about the NICE guidelines which have been put out there and the recommendations for the management of this condition. It's really important that clinical commissioning groups and their counterparts in the devolved nations put in place services to meet the needs of people with long COVID. And that means bringing together specialists from specializing in different parts of the body, but also different types of therapists, psychologists, occupational therapists, physiotherapists, and others. And crucially, the patients are playing a really key role, because those who have been affected by long COVID have done a great deal to get this condition on the agenda of policymakers to understand that it is recognized, and they are an incredibly valuable resource in going forward. But there's a lot more research to be done on this condition. And it will be very important to monitor what we know and what we don't know, and certainly looking forward what the course of this condition will be. And I'll stop at that point.
Thank you very much, Martin. And that new report on long COVID is up there on the website, and we hope that that will be a useful resource. Now, I'd like to invite our first guest speaker of the day, respiratory medicine consultant, Dr. Sarah Elkin, to speak. Sarah.
Lovely. Thank you so much for asking me to come and speak, everyone. I'm just going to get up a few slides and I'll put them on main. So I've been asked to talk about what the plans have been across the UK and in London especially, and also to talk about the challenges that we've had. So in a nutshell, this slide shows what the NHS plans have been. We've now got a case definition for long COVID. We've got some guidelines, and I'm very pleased to see the addition from Indie Sage, which are really valuable. There is an app that's come out called Your COVID Recovery Phase 2, but again, there's been some issues with this as regards governance within the individual trusts, and also Wave 2 came along just as we were beginning to utilise this. There are designated long COVID clinics being set up across the UK. They've started in many places. However, again, Wave 2 came along and we had to pull back staff into the trusts. However, they've been going in 1 or 2 places in each of the areas in the UK to keep the flow moving. The clinics have been debated what they should involve, but essentially they should be an expert one-stop service feeding into pathways across the community to ensure that care is given nearer to home. The one-stop shop is turning out to be difficult in many parts, in that when we meet these patients, we want to watch them in time and make sure we have an understanding of the trajectory of disease. There is good news in that there's a big funding research line through NIHR coming through that will be announced hopefully within the next few weeks, that will allow us to go through for more treatment trials and understanding more. I'm showing this slide with one point really, that the whole point of the post-COVID clinics is to get a personalised care plan. And personalised is the word I want to use here. Everyone's symptoms vary. Their routes into post-COVID is different, i.e. they may come from primary primary care, having always been in the community, never having touched a hospital space for myriad reasons, and they might come from the hospital. We're learning a little bit about the cohorts and the symptoms that people have, and therefore we may be able to direct treatments in time at the right treatment and right symptom. So what are the challenges? I'm going to go through these. These are really queries that we have as a group of people caring for people with long COVID, but there's definitely an increasing need. I mean, you've just heard the stats. It's now estimated there are approximately 300,000 people with symptoms at 5 to 12 weeks post initial symptom in the UK. That's a huge amount. And have we got the capacity of staff and expertise in the staff to do this? We definitely need more funding and resource put in. Staff training capacity, I've put this down because actually skill sets are different for this. Whilst we have our specialties in different places in the hospitals, we do need to have people that have skill sets in fatigue management, in physiotherapy. So our therapist data needs to, resource needs to get larger. We need to define and understand the causes of long COVID more. We need to understand the different patterns of symptoms, as said before, and we need to understand time to recovery. We need correct information with this so we can communicate properly. I think the anxiety linked to long COVID is totally understandable. This is, anxiety, we all get anxious in our life, and the anxiety linked to long COVID, totally understandable. People just didn't understand what was happening at the time, nor did we. And I think we've learned with this, but now we need to share that data back. We need to understand the value of diagnostics, both over and under use. What do the investigations that we're doing mean? How will they feed into treatments in the future? And we need to have a correct modelling, as said before. How many clinics do we need across the UK? How many clinics and therapy do we need in the community to deliver programmes? We need to make sure the services address the needs of individuals, and then hence we need to work with patients that have long COVID to understand what the needs are, and also their families. And we need to reach out to the harder to reach populations and to decrease the health inequalities that COVID has exposed. Treatment trials, really important, and it's really important we work together across the UK for these. Lots of different things there at the moment, things like colchicine, beta blockers, antihistamines, but we don't know whether they work, and we still don't know which patient groups they may work on. Also, we need to make sure that digitalisation of care and models of care is right. I think they work in certain people. And also, if we can do digital approach like we are now on Zoom to more people to educate and communicate wellness, then that might also help. So lots of work going on in this space. And I'm going to stop now because I'm sure some questions will come through that we can address.
Thank you so much for that, Dr. Elkin. And now I'd like to introduce our second guest, Dr. Nisreen Alwan. Nisreen.
Thank you, Independent Sage, for inviting me. Okay, I got COVID symptoms back in March, so I'm a first waiver. I wasn't ill enough to go to hospital. In fact, I wasn't that severely ill at all, but the symptoms kept fluctuating and relapsing over the next 9 months. Some disappeared, new ones appeared, and some stayed the same. With my caring responsibilities and not knowing what this is and how it will end, it's quite distressing. But I'm one of the lucky ones, really. There are so many who had much more severe symptoms than me. I was also fortunate in that I was able to adapt aspects of my life and continue to function for most of the time by avoiding activities and situations that I've learned they trigger my symptoms as much as possible. Many people can't afford to do so. It's very important to point out that I'm only one. My story may be totally different to thousands others living with long COVID. That is why the name long COVID is the most appropriate one for now, rather than names that assume non-established certainty about the underlying mechanism, because long COVID is an umbrella term that does not assume knowledge other than the knowledge of not recovering, that the illness is long. It's likely that there are multiple underlying mechanisms at play in people with long COVID. What we do know is that long COVID is not uncommon. So the Office of National Statistics estimates are 1 in 10 people at 12 weeks from the onset of their symptoms or their positive test, and 1 in 5 people at 5 weeks. That's a huge number. This is basically out of everyone infected with COVID-19, including the asymptomatic people, in working out these statistics. COVID-19 leads to severe morbidity and organ damage in some people. Some NHS data analysis of almost 50,000 hospitalized patients in the UK, in which only 10% were admitted to ICU, the rest were admitted to hospital but not ICU, show that within few months of discharge, almost 1 in 3 people hospitalized initially with COVID get readmitted to hospital, and sadly 1 in 8 die. They suffer much higher rates of heart, liver, kidney disease and diabetes compared to people who've not had COVID. So applying the basic principles of public health, there are really 3 levels of prevention with regard to long COVID. First, there's primary prevention, and that means preventing people getting COVID in the first place. For that, we need public health measures to control the spread of COVID-19, aiming towards elimination. That also needs telling people about the real risk of getting long COVID, even if they are younger or fit and healthy, so that they make informed decisions about their behavior. We still don't know who is more vulnerable to long COVID. So this really requires clear messaging to the public. Now, secondary preventions mean that we prevent COVID, so people who get acute COVID, from progressing into long COVID. We really need research to tell us what early treatments and interventions are effective, even in non-hospitalized patients. And then there's tertiary prevention, which is basically mean treating people with long COVID and improving their quality of life. That one happens when the condition is properly recognized and everyone with it given a thorough physical assessment and appropriate medical investigations to detect any possible organ damage or any treatable pathology. The all-party parliamentary group for coronavirus demanded 3 things in the first ever parliamentary debate on long COVID a couple of weeks ago. And these 3 things were: first, reporting; second was research on mechanisms of therapy; and third, very importantly, is recognition. And that includes employment rights, sick pay, and officially recognizing that certain occupations are at a much higher risk of exposure and getting long COVID and need adequate protection, and including PPE. I agree with all of these recommendations. And this really links to the serious issue of widening inequalities. It's a vicious cycle. Disadvantaged people are more likely to be exposed, to get long COVID, but they're also more likely to not get the recognition they need for that condition, so not get sick pay to rest and recover. And this really leads to financial ruin and more deprivation and disease. For the last minute of my talk, I just want to say a bit more about the number 1, which is the reporting. Counting long COVID is something I've been calling for many months because we can't fight what we do not measure. So how do we do it? Again, number 1, as Martin mentioned, establish patient registers. For that, we need universal and inclusive clinical diagnostic criteria, which are not dependent on lab testing and confirmation. This is essential to avoid a postcode lottery due to variation in diagnosis. This also needs a proper coding in electronic health systems. And number 2, following up, we need to follow up all of those with acute COVID who test positive using existing infrastructure such as the test and trace system to assess recovery. And this could be through simple text messaging. So we need to have illness statistics informing our pandemic response, not only death statistics, hospital admission and positive tests. And these illness statistics could include the proportion infected and not recovered by 4 or 8 or 12 weeks, the proportion with complications and organ damage following COVID-19, proportion readmitted to hospital, the proportion off work due to long COVID and complications of COVID-19, and the proportion recovered from long COVID to be helpful because some people do recover from long COVID. So let's hope that last proportion is high if we do the right things. Thank you.
Thank you very much indeed, Dr. Ulwen, for that really interesting combination of a personal and a clinical perspective there. We're now going to open up to questions, and we start with some questions from members of the press. And first up, it's Graham Lawton from New Scientist. Graham, are you there?
I am. Thank you for taking my question. Neurologists are increasingly concerned that we may be storing up an epidemic of neurological disease, neurodegenerative disease due to the virus and the immune response, which will become a very long COVID, if you know what I mean. I wonder if anyone could comment on that possibility.
Thank you very much. Dr. Elkin, would you be able to start with that one, talking about the neurological
Thanks, Graham.
dimension?
I think it's a good question. I work very closely with neurologists, and I suppose what I would say, it's very important to have a neurologist as part of your MDT in your long COVID clinic to make sure we capture what may be occurring. So we don't know yet. We need to follow up people long term to understand this further.
Thank you very much. Dr. Alwan.
Oh, I completely agree. And I want to add the concerning thing from the symptoms description that we have from surveys of people on COVID. It seems that the cognitive dysfunction may not be necessarily there at the start of the infection for many people, and it starts to appear, weeks or a couple of months after. So that includes things like poor memory and brain fog and other neurological symptoms. So there's something going on there in terms of why are these symptoms appearing a bit later that we really need urgent research on.
And Professor Gabriel Scally, you'd like to respond here?
Well, just to say that as well as the issue of those who have long COVID, I also have this fundamental worry that the virus may do something to the brain that won't produce symptoms now or problems now, but may do in the future, looking back to the Spanish flu and the suggested connection between the Spanish flu, even in people who weren't deeply affected by Spanish flu, developing Parkinsonism some years later. So I think the fact that it affects the brain is known, and it's one of the reasons why we should do everything we possibly can to suppress the virus as far as we possibly can. Thank you.
Thank you.
Thank you. Thanks, Gabriel. Thanks for that question, Graham. Moving on now to Phil Whitaker, who is doctor and medical editor of The New Statesman. Phil.
Hi, thanks very much for inviting me on. I think just from my clinical practice, probably the thing that's most interesting to me just at the moment is how we try and sort out different groups under the umbrella. So it seems to me there are probably sort of 3 overlapping groups under that long COVID umbrella. People who've been in intensive care for any condition will tend to have long-term health problems from just an intensive care admission. And that will also apply to people on ICU with COVID. Then we know that COVID causes a lot of damage other than in the lungs. Obviously, the lungs are very, very important, but other organs affected, such as heart, muscle, kidneys. So these we might kind of perhaps directly relate to sort of viral damage at the time of the acute infection, but they're going to leave ongoing health problems. And then there's this third group that I think Nisreen was probably including herself in, and I've seen time and again in my clinical practice. Very often people who haven't been anywhere near a hospital at all, maybe not been particularly sick at the outset, who just get this what I've called relapsing, remitting COVID, just going on and on and on with changing patterns. And this seems to be something a little bit different to those other 2 groups under the umbrella. I'm just wondering how important we feel this is to try and get differentiation so that we can understand perhaps very different pathological processes that are going on.
Thank you very much, Phil. Dr. Alwan, would you like to start with that one?
Yes, I agree. We really need to, it's the patterns, it's looking at the patterns. And one pattern which is probably the most concerning is if you're not hospitalized and it wasn't severe in the first place, and then it really gets much worse and worse with time, which doesn't seem to be the majority of people, but I think there might be a significant minority that this is happening, and we need to understand why this is happening. What can you do at the acute phase, I suppose, is to prevent it from happening. So yes, I think the general the common thing is what you just pointed out, the fluctuating. I mean, in my case, I would call it fluctuating at the start of the first couple of months, and then it became, like you said, relapsing, remitting, where you would have some period where you think, I'm almost there, that's it, it's gone, and then it hits you, and there's a huge psychological element in that, because every time you're hoping that's it and you finish, and then something hits you, and you learn to know the triggers a bit. But sometimes you don't. Sometimes it happens and you don't understand what the triggers are. So I think even in that group, it would be helpful. It would be really good to have some research to try and even prevent these episodes of relapse.
Thank you very much. Professor Kamlesh Kunti, I think you wanted to share your perspective here.
Yes, the issue is that it's very difficult to determine who will get long COVID. Because people have been admitted to hospital, that doesn't always translate that they're the highest risk of getting long COVID. So a recent study of 200 people where they examined them very thoroughly, they had scans done on them, and that showed that only 18% were admitted. Despite 82% not being admitted, they had the same issues in terms of long-term symptoms. So symptoms about tiredness, about fever, about cough, as well as that, the impairment in terms of the lungs. When they did the scans of the lungs, the heart, the kidneys, 33% had lung damage, 32% heart damage, kidney damage in 12%. But you couldn't determine whether they were admitted or not. So if you look for even the ones who haven't been admitted with mild disease, still have issues in terms of not just the symptoms, but organ damage as well. And I think there's a lot more work that needs to be done in that area.
Thank you very much. Professor Susan Mickey. Did you want to comment here? No. Anthony Costello, Professor Anthony Costello.
Sorry. Yeah, thank you, Phil, for that distinction. And I'm sure there are other ways we can divide it. One concern I have is that the Office for National Statistics have suggested that 5 weeks after testing positive for COVID-19, 15% of secondary school children and 13% of under 12s are still struggling with symptoms. Now, that's after a test for positive. Presumably, many of them were already symptomatic. So we're not quite sure whether it's of all children or those that were symptomatic. But nonetheless, that's a very worrying figure. And it raises for me, and I don't have the answer here, whether we should be moving children, into the vaccination list. I know the trials have not yet been completed with children, but one must assume that they're going to have a decent response. And how we achieve that quickly, whether we do this, because we could be storing up a whole heap of problem for children. And I hate to raise that because it's, it'll scare a lot of people, but we have to face reality.
Thank you very much, Anthony. And thank you for the question. I'm now moving on to the next question from the press, which is coming from Nigel Nelson of the Sunday People. Nigel.
Thanks, Alice. This is a vaccine question as a follow-up to what's just been said. This week, the CEO of AstraZeneca, Pascal Soriot, said one dose gives 100% protection against severe disease and therefore hospitalization. Clearly, this would be a game changer because it would stop the NHS being overwhelmed. There's now some doubt, though, whether it's 2 doses for the 100%. If it's 1 dose, then the government's current strategy must be right. But if it's 2 doses, does that mean it's wrong?
Thank you very much, Nigel. We've tackled this question before, and it is a tricky one because obviously the data are evolving, and it's an ethical question as well. So I wonder who would like to start with that. Professor Martin McKee, and then I'll come to you, Professor
Thank you very much. Yeah, thanks. I think the thing we have to remember is that there are a number of mechanisms by which COVID can lead to long COVID. So you've got the direct cell damage during the infection. So for example, damage to the heart, damage to the islet cells in the pancreas causing diabetes. And then you have the effect on the blood vessels leading to blood clots, which can lead to cell death. But then looking ahead, there is growing evidence that there may be an autoimmune phenomenon developing where the body starts attacking the immune system starts attacking the body, parts of the body in the longer term, as well as some recent rather disturbing evidence that the virus may be able to persist in the brains of some, certainly in animals anyway. So the thing is that the vaccine will protect against some of those, but not against all. So we've really got no good evidence yet that the vaccine will protect against long COVID. And I think that's really quite important. We need to know that, essentially.
Thank you very much, Martin. Professor Dean Pillay, the question also was asking about that enduring question that we have at the moment about 1 or 2 doses.
Yeah, thanks, Alison. Thanks very much for the question. Just briefly with regard to the protection, it is the case that both in the AstraZeneca Oxford trials and the Pfizer trials, it was not only protection against disease, but there was very strong protection against hospitalizations and severe disease. There's no doubt about that. Having said that, the data you mentioned that AstraZeneca, I've heard various representatives talk to saying that, in fact, the longer the gap between the first and second dose, the better. Certainly, I've not heard anyone saying that 1 dose full stop will be sufficient, but I've heard that 2 doses a long period apart, maybe better than shorter gap between the doses. But I stress, I've not seen those data anywhere other than through presentations, including to the Select Committee for Health. So I do think you're right to be asking for those data to become available. Thanks.
Thank you, Professor Pillay. I mean, can I just ask, presumably there are large-scale phase 4 trials that are ongoing now in the UK that we'll start to get data from relatively quickly?
If that's a question to me, Alice, I know that there is... so we've got to be careful. The AstraZeneca trials included a variation in timing between doses up to 12 weeks. So I think the question here really is for the Pfizer vaccine, where in fact the trial, as we know, was only for 2 doses, 21 days apart. I certainly, and many others I know, have written and are asking for these studies to be done. I've heard Public Health England say that these studies are in the pipeline, but I've not yet seen any protocols circulated or anything, which I think would be incredibly helpful at this moment in time when it remains a concern of people whether they're getting compromised vaccine by just getting 1 dose and waiting for the second dose.
Thank you very much for that. Is there anybody that would like to comment at this point on the question, so long COVID and vaccines? Okay, I'll move on to our next question then. Thank you very much, Nigel. Next question comes from Claire Hasty, who is the founder of the Long COVID Support Group on Facebook, which now has 34,000 members. Claire.
Hi, thank you very much for everyone's work. I really, really appreciate it. One thing that I'm really, really trying to push for, and having meetings wherever I can in different countries, is we need to turn the tap off. We need to stop more cases of this happening. We don't want our group to be any bigger than it is. We don't want our group to have to exist. The vaccine feels like one leg of the stool. They've got all the issues that you just talked about, skepticism, is it going to work? Will kids get it? When will I get it? All that stuff. We absolutely need to be looking at early interventions at the earliest opportunity within 24 hours of symptom onset. I know there's the Principal study, which looks like it's doing great work. There are questions as to the recruitment window being too long potentially, and also the drug candidates that it's looking at. I'd like to use a concept from the business world of the hackathon, where you get lots of brains in a room from different disciplines. You get them in a room together, you give them a single-minded question to answer. We need to be administering oral drugs at the first tingle of the cold sore. When you get a cold sore, you stick some cream on, you stave it off at the pass. If we can solve that problem, we can prevent acute severe cases and help the NHS from collapsing and all the staff burning out. We can prevent long COVID. What can we do to single-mindedly get people behind that concept?
Dr. Elkin, I wonder if I could come to you first on this one, and then Professor Susan Mickey.
I completely agree with you, Claire, and I've been really lobbying with all my peers about this to say, you know, vaccination will be one part of the jigsaw, but it won't be everything. There are trials coming through to Principle now, and apart from Principle too. So there are, I know some groups looking at nebulized NO as well as the interferons, but the NO might work, but it's not going to be one thing, I fear, at the moment. And I think you're right, we need to all get into a group and decide what may be the right way forward.
Thank you very much, Professor Susan Michie.
Yeah, I absolutely agree with you, Claire, that the way to get long COVID driven down is to drive down COVID to begin with, you know, even before the immediate treating. And I know we sound often in this group like a bit of a broken record because we keep pointing out that the countries around the world that have really successfully driven down community transmission of COVID have done it using effective test, trace and isolate systems. And we've been calling for this for a long time. I think there's more awareness now of just how poor isolation is because there's not enough practical and financial support. But I think having seen how brilliantly the NHS is rolling out the vaccination programme, I think we now need to call for a real rethink of the whole way test, trace and isolate is done and bring it properly into the local communities with the local authorities, primary care, coordinated by the NHS, and roll that out and in a supported way so that we just drive down the number of people who are getting COVID to begin with.
And we also need to stop unwitting spread. We need to do something that is free and would take approximately 3 seconds. We need to copy and paste the list of symptoms that was on the WHO website back in spring last year. We need to paste it so that when you Google NHS COVID symptoms, it comes up with more than just fever, cough, and loss of taste and smell. People right now are wandering the aisles of Tesco who've had diarrhea or COVID toes and are unwittingly spreading the virus.
Thank you, Claire. Dean, and I think you wanted to come in on that as well.
I really thank you, Claire, for that for the question. Really important, and Sarah and Susan gave some really good insights into this. I think it's one of the failures of the scientific development and response so far that we've not developed, or there's not been as much stimulation of developing specific antiviral drugs that can be used safely and orally early on infection, because of course this infection just starts off as a viral infection, even though of course as it progresses there's more immunological mediators needed, and the focus has been through the Principle trial, but also other trials of what we call repurposing existing drugs that are used elsewhere, because of course they're already licensed and it's easy to implement. But of course we know that hydroxychloroquine, doxycycline, azithromycin, and drugs such as these have shown to be ineffective, unfortunately. And I know it's a concern in many areas that we need to really stimulate in the same way that we've stimulated vaccine development with an absolutely fantastic delivery of now, as we speak, 4 now or 5 it is licensed vaccines that have worked. We really don't have that pipeline of drugs such as oseltamivir, otherwise known as Tamiflu, for instance, which works somewhat in flu, but nevertheless is the sort of drug that one could have at home, is safe and could use as soon as symptoms start. But were
they all tested at the right time, though, is a question, I think, because I think in some trials, if your recruitment window is 14 days, the cytokine storm may have already happened, and it might be that those drugs could potentially be effective if they were tested within 24 hours of symptom onset. It's just a question. I'm not a scientist, but it's just a question.
It's a very good point, because of course the earlier, for a viral infection, the earlier you use a drug, the more effectively you drive down the virus, and therefore you limit the follow-on aspects, like you say, cytokine storm and so forth. And of course these do need to be primary care, community-based trials. They can't be hospital-based trials, but they do then depend on very rapid, exactly as you've outlined very eloquently, very rapid identification of symptoms and presumptive diagnosis, as well as the ability to test very easily, through point of care tests. So very important point. Thanks.
Thank you very much, Dean. And Tallulah Onie, Dr. Tallulah Onie, you want to comment here as well?
Yeah, thanks. I just wanted to go one step further. So that's, I think, the points, I agree with the points that have been made. And one step further to come back to the point that Dr. Alwan made around the importance of primary prevention, and to bring together two words that hardly ever come together, which is innovation and prevention. So often when we talk about innovation, it's often in the context of treatment and that side of things. And there's so much more that can be done in the context of primary prevention and innovative approaches to integrate our approaches. So for example, we still have a very siloed approach to thinking about how do we prevent long COVID? How do we increase vaccine uptake? At the same time, we know that the same issues, so the inequities, so that's a cross-cutting issue of the inequities of vaccine uptake, are the similar patterns from the inequities of vulnerability to COVID, the similar patterns of inequities with respect to the consequences of long COVID on multi-organ damage, etc. So can we think differently about more comprehensive approaches, rather than thinking all we're doing now is increasing vaccine uptake? Because in the same populations where you have a lower vaccine uptake, you also have these health inequities. So there've been interesting examples, non-COVID. So for example, increasing antenatal uptake in other countries, and integrating that with financial security, community-based approaches that were already underway, because the reality is we can't define what people think are important. And sometimes I think as health people, we have that hubris. I think you think this is important, but right now I'm knocking on your door and the most important thing you need to be worrying about is vaccine uptake. That is somewhat artificial. I think when we start thinking about how do we improve vaccine uptake, we have to first understand some of these existing health inequities and those upstream socioeconomic factors that drive that, and the innovations at the community level that are already underway to address those. And can we then superimpose our strategies to increase vaccine uptake as part of that? Those are the kind of exciting innovations that I think it would be great for us to see ourselves beyond just this particular goal of vaccine uptake. Because otherwise, the point that Anthony made about starting to think ahead of if down the line we foresee needing to vaccinate children, are we thinking ahead about vaccine uptake in BAME groups and children? So what do we need to be thinking now about that? How can we build in our community strategies now for the uptake for the adults to build that trust, so that if we get to a position where we're now having to vaccinate children, we don't have to start from scratch again, saying, how do we build the trust to get children vaccinated? So I think equity and innovation in primary prevention is we have our work cut out in that regard, I think.
Thank you so much, Claire, for that question and your comments and your insights and that need for a holistic approach to all of this. Moving on now to our next question from Anna Whittekund in Buckinghamshire. Anna.
Good afternoon, everybody. My question sort of follows on and is slightly related and linked to Claire's question. And excuse me for reading it, but I am suffering a bit from brain fog myself this afternoon. So my question is, to what extent is the committee aware of research being undertaken to understand the cause or causes of long COVID? And do they consider this level of research is adequate? I'm thinking mainly in terms of addressing what we think are the main hypotheses out there, which appear to either relate to viral persistence, whether we are harbouring reservoirs of live virus somewhere in the body, or continued exposure to dead viral particles, and or related to a hyperimmune response that is reacting to triggers that your immune system shouldn't be responding to, resulting in inflammation and ongoing symptoms.
Thank you so much, Anna. Professor Martin McKee.
Well, the largest study worldwide at the minute is the post-hospitalization COVID study being led from Leicester. And as I mentioned, Kamlesh is one of the co-investigators on that. And they are doing a lot of, basically assembling 10,000 people and doing as many of the studies that you described that they can. And I think that will yield quite a lot of very valuable information. But clearly, there's much more that can be done. I think obviously this is going to be a problem for a long time, and I think that's a good platform to do the studies, but it will be a matter of continuing and thinking of new hypotheses that can be tested.
Thanks, Martin. Dr. Elkin, and then I'll come to you, Dr. Alwan.
Hi, Anna. Yes, I think it's a very good question, and probably the answer is at the moment not enough. And I think we need to start doing more research in this area. PHOSP does look at so a lot of people that have been in hospital, but does it look at the ones with the relapsing type pattern of COVID? So there's a lot more understanding we can get, and the NIHR grants that are coming out now will address that. So I think we're about to embark on a lot of research into this, and I just hope that all the post-COVID clinics across the UK join in and get resources together.
Dr. Alwan.
I just wanted to say the same. Really, there's been a funding call for non-hospital long COVID non-hospitalized patient, and hopefully the results will be announced very soon. So you'll be seeing. So that's a UKRI and IHR call, which Sarah mentioned, and hopefully there'll be more research. The studies should be starting soon, very soon after the funding call results come out. So we'll be, we'll hopefully be seeing more of that. Can I just say, I'm sorry, I'm being opportunistic here, but the point that Claire mentioned about children's symptoms, well, overall symptoms, because I still, I don't really understand why the symptoms are very, only the 4 symptoms on the NHS website up until now, where we know the symptoms are much wider, but particularly around what Anthony raised around children and the prevalence of long COVID. The children tend to have different symptoms, and all of these times since the start of the pandemic, it could have been that a lot of children might have had COVID but presented with different symptoms, for example, diarrhea, abdominal pain, rashes, which were never tested. And even if they had prolonged symptoms, nobody's attributing them to COVID-19 now. So I think, we really need to, again, there's a dichotomy, because we went into testing and there was so much focus on lab confirmation testing, and the characterizing symptoms and paying attention to symptoms got a bit neglected, and we've got enough data now to do a bit better on that.
Thank you very much, Dr. Alwan. And we know that children who were suffering from the wide range of symptoms were specifically told not to stay off school and not to get tested as well. I'm going to move on to the next question now, which comes from Louise Flanagan in Cambridgeshire. Louise.
Hello. You've already touched on some of my question, really, with the points just made, but parents are told that children don't get seriously ill with COVID, especially in discussions around schools and safety measures. And I wondered if we actually know what percentage of children do suffer long COVID, and what their typical symptoms are, because like you say, often initially the symptoms are very different to adult symptoms. Is that the same with long COVID?
Thank you very much. Can I come straight back to you, Dr. Alwan?
Yes, sure. So there are the statistics from the Office of National Statistics Anthony mentioned, and basically what they did is from their ONS prevalence survey, they've asked about the symptoms that was in their list. So there wasn't a very wide range of symptoms, is what was identified as COVID symptoms. And the figures about, children having symptoms 5 weeks from positive tests were, about 1 in 8 for under 12s and 1 in 7 for 12 to 16. So they're quite concerning. There's very much less research, even in long COVID, for children compared to adult. There's been I saw a new study coming from Italy with a small sample of children following them up, but there wasn't much detail. But it was also some concerning prevalence of persisting symptoms after a while. We just need to do better. And we need to compare, really, because the main argument is that people might say is that, well, these symptoms could happen incidentally, so people have COVID and the non-COVID children as well. I don't believe so, but we have to prove that by comparing the level of symptoms between, children who tested positive and children who didn't. So there's a lot to do there. But it's there. Long COVID is there in children, and we need to move beyond that, that argument of whether it could ever happen.
Thank you very much, Dr. Alwan. I want to squeeze in quite a few more questions, so I'm going to move on now. Thank you very much for that question, Anna. Louise. The next question comes from Sammy McFarland, who's the founder of Long COVID Kids. Sammy.
Hi there, thank you for having me. Yes, so we would like to ask that given that Long COVID Kids represents over 1,000 children who have failed to recover from their initial COVID infection. COVID is airborne, so what can individual schools do in the absence of government support to protect children and communities when they're forced to return to school? Thank you.
Thank you very much for that important question, which we've looked at before, and Independent Sage have published several reports on safe schools. Who would like to talk about that? Who can I come to first before I pick on somebody? Dr. Zubaida Haque.
I'm happy to start on this one. As you may know, Sami, we've been talking about this for quite some time, and at the moment, COVID secure measures in schools are wholly inadequate. They're wholly inadequate because the government have done very little to change the environment of schools. All the effort has been on mass testing, on the mantra that schools are safe, without actually doing anything. And the key measures that we have wanted from the outset is smaller class sizes, more so that more social distancing can happen. Last summer, we suggested that the government even requisition all the unused buildings, or rent lots of unused buildings, whether sports stadiums or community centres and so on, and spread classes out. We still think that that's a viable measure. That's not being done. Ventilation is hugely important. The government have spent very little effort on that, and we know at the moment a lot of schools are very old. A lot of secondary and primary schools are very old. It's harder to open windows, so there needs to be more ventilation systems being put in. There are also the issues that the more accessible and easy to use measures, such as masks. And we have suggested from a very early stage that secondary school children, for instance, can wear masks. And of course, there is the more trickier issue around PPE, which is still being discussed for teachers. But none of these measures have really been entertained by government. They've really sent out some sort of poor guidance. So it's very difficult to know what else teachers can do, because if they can't play with space, the most they can really do is have a rota system where children can come in on different rotas, and on 1 week in, 1 week out, 1 week on remote learning, 1 week in classes. But beyond that, it's very, very difficult to know. Actually, we think this needs to be passed back to government where they do something.
Thank you very much, Zubaida. And Professor Stephen Reischer, you'd like to comment here as well.
Yeah, on the grim day earlier in the week when the death toll passed 100,000 and Boris Johnson said, "We truly did everything we could." What depressed me about it was not so much that it was patently untrue, but it indicated that the government is not going to do the obvious things it could and should be doing. Schools is a very obvious example, and the sooner you make schools safe, the sooner you'll be able to reopen schools, because of course there are harms from schools closing. We want schools to be open. That's why we want them to be safe. But what's happening to schools, I think, is emblematic of something wider, and one of the fundamental problems since July the 4th, when we reopened after the first lockdown. And that was very much a hands-off attitude, saying not just to schools, but to everybody else, make things safe. Government won't take responsibility. You make things safe, make workplaces safe, make hospitality places safe, make schools safe. And one other figure that came out last week, which to me is quite shocking, is that the Health and Safety Executive have had 97,000, so nearly 100,000 complaints about unsafe spaces. They have issued enforcement notices in 0.1% of cases, and no legal action, not a single piece of legal action has been undertaken to make sure that our community is safe, that the spaces we go into as adults, as children, are safe. And it seems to me that a fundamental thing that needs to happen, beside the test and trace issues, which Susan's talked about earlier, is to do far, far more to make sure that our communities, our schools, our workplaces, our hospitality spaces are COVID secure. And that's not just a wish and a prayer, but it's actually backed up by clear support by clear implementation and certification, and making sure that if spaces aren't safe, then they don't remain open. And I think this is one of the huge holes in the response, and something that the government very much needs to do as a matter of priority.
Thank you very much. Professor Gabriel Scally, you wanted to comment here too, I think.
Yeah, just a slightly different approach to life, which probably reflects my background and my upbringing. And that is, students are not passive recipients of what is done to them. And students have a real role to become activists in this themselves. Just think of all the aspects of school functioning, of what they're learning that is important, particularly at secondary schools, about science and about social sciences, about law. And students should learn about issues of ventilation, be able to assess themselves, their classrooms and the spaces in which they are expected to learn, and become activists. You're not passive. You're activists in lots of parts of life, and this is a good one to start, and contact the headmaster and the teachers and the teaching unions and your local councillors and your local MPs, and tell them of your concerns if you find yourselves being placed into spaces that you think are unsafe. You've got the right to a voice as well.
Thank you very much, Professor Scally. I'm going to move on to our final question now, which comes from Catherine Howard in Berkshire. Catherine.
Hi there. Thank you for taking my question. It has already been answered in part. And I just want to give a quick background. 33 years ago, I had a viral illness that I've never recovered from, never had the symptoms explained, including brain fog and all the symptoms you've been talking about, never had any treatment. And I think it's imperative that there's comprehensive research done on physical mechanisms for long COVID, because there's thousands of people that could potentially be in my situation in decades' time, and that would be an absolute tragedy. And just really a plea, don't be sidelined into simplistic notions that just pushing through and being positive can cure this. It can't. And I would say, from my experience, as soon as you get a viral illness, rest as much as you possibly can, and then as you recover, pace. So that was just my background. I was originally going to ask about whether the vaccine will protect against long COVID, and that was touched upon earlier. But also, if there are some people that have an abnormal immune response to to the virus, could they still have that adverse immune response to the vaccine as well? So just a little bit more about how the vaccine would protect against long COVID, and maybe if there's any dangers of the vaccine.
Thank you very much for that question and that perspective as well, Catherine. Who would like to tackle that question about vaccination and immune responses? I wonder if I could call on you, Professor Anthony Costello.
I was hoping Deanan was around, but he seems to. Well, you know, an earlier questioner and Martin referred to all the different mechanisms that could happen and the whole relationship between viruses, the immune system, and how viruses predispose to later conditions is an immensely complex one. I think your question is a really good one about whether a vaccine to someone after they had had symptoms could trigger one of the adverse effects.
Yeah.
The answer is we don't know. I think that's fair enough, unless Nisreen or Sarah have any thoughts about that. I would still go ahead with the recommendation that people who've had it should get the vaccine, on the grounds that they don't want to get it again. And it should boost their immune response in a way that's positive rather than negative. But you've raised a whole number of issues which are prevalent across all aspects of medicine, because we're continually exposed to viruses. Children are continually exposed, and by and large, we cope with them. But everyone has a different genetic makeup. Everyone can respond in a slightly different way. And as we've seen with this virus, and indeed with other viruses, it can trigger these abnormal immune responses that can be sometimes catastrophic, sometimes in between, and cause an acute illness. But there are others that sadly do seem to have chronic result, like yourself. And the mechanisms are by no means clear. And one of my fears about long COVID is that we won't be able to unpick all of this because we won't absolutely know in the asymptomatics whether they ever had COVID or not. So it's going to be quite difficult to unpick, but I'm sure Martin would have something to say.
It looks like he does. Yeah, Martin.
Well, as far as I know, and obviously I haven't read all the details yet, but I think that the Novavax trial, the study in South Africa, did actually have a number of people in it who'd previously had COVID or they had antibodies beforehand, and the vaccine did seem to give additional protection on top of that, as I understand it. But again, I think we need to see more on that. But I concur with what you say.
Professor Carl Friston, I think you wanted to make a point here as well.
Yeah, I'm just listening to the conversation from the point of view of a sort of neuropsychiatrist, and I've learned a lot. And I'm just putting the themes together about children, long COVID, long-term implications of contracting that. And it strikes me that this issue, that there may be long-term implications of contracting the virus, is particularly acute from the point of view of sort of pediatric neurology. And this is really a question to my clinical colleagues. I mean, there strikes me that there's a number of sort of models that one could bring to the table here, things like Creutzfeldt-Jakob disease or multiple sclerosis, all implicating some kind of viral or prion infection and or an autoimmune response that induces synaptopathies, white matter damage, damage to the connections in the brain that may unfold over years to come. If that's true, I think that has serious implications for the previous answers to the previous question, which about school reopening. So previously, and just to say that this is a really prescient issue, because of course, reopening schools is going to be the sort of the test case, the showcase for unlocking in the context of the declining death rates and the increasing vaccination rates. So this is what the government are going to be worrying about most, how to unlock and reopen schools safely in the next few months. So at the moment, I think most people have been thinking about schools as sort of, from the point of view of the population, as amplification devices and not worrying about the kids. But if it's the case that the kids may, or a very small minority of kids, may actually be exposed to long-term problems of a neurodevelopmental sort that may manifest in adolescence or even in adulthood, I think that puts a very different picture on the sort of the imperatives and sort of pushes you back to a complete suppression strategy as opposed to a containment strategy, which would be normally the approach one would advise schools to respond to. So I'm just opening up more questions than supplying answers, really.
Carl, would you go for putting children higher up the prioritization for vaccination, assuming that the early trials show that they tolerate it well? I know we can't guarantee that a vaccine will protect against long COVID, but it seems a precautionary principle that, maybe they should be the next in line rather than people like me.
Well, before this session, I would have said no. Now I'd say yes, or at least it should be taken very seriously, yeah.
Thank you very much. And Dr. Alwan, you've got a comment here as well.
Yeah, very quickly on Catherine's point. The first one is vaccine and long COVID. I mean, it's always a balance of risk. And until, I think my position is, or my opinion, we don't have, like it's been pointing out, we don't have evidence, and we don't have evidence of harm. So people with long COVID would not want to have it again. So I think in the absence of evidence of harm, then that, vaccination, even people with long COVID would be encouraged. And the other point, the point you made, Catherine, about, how, this is a similar to, post-viral syndromes, and obviously, long COVID has been talked about in terms of how similar it is to ME and CFS, and I just want to always think about, always point out the silver lining that if long COVID will get attention and research and understanding the mechanism, that would benefit all of these other conditions. It's not a competition. It's not a competition between long COVID and other chronic conditions. If long COVID is benefited by research and treatment, the other conditions will benefit too. And I just want to make that, point, because everybody in the long COVID community now understands me, for example, I now understand more about the experience of people with these chronic conditions. So that is, in a way, is a positive thing, because you have more understanding as society and therefore more drive to do something about it.
Thank you very much, Dr. Alwan. We do like to end on a positive note, and I am going to draw it to a close now, but not quite yet, because I would like to invite Sir David King for his summary, as usual.
Thank you very much, Alice. Well, once again, I think this has been a very instructive period. Long COVID has not really received nearly enough attention, and so we filled that gap, and I think we're filling it quite well. We need considerably more work on this. We are looking at a very large number of cases in the United Kingdom. We've had the number 300,000 as the estimate, and this is a long-running disease, and we need to understand how to manage it and how to deal with the various disease factors that emerge. Can I just offer congratulations to the government? And I know we don't often do this, but for the vaccination program and the way it's rolling out. 300,000 per day, and this vaccination program at scale has only been running this month, is one tremendous achievement. And so congratulations on that. This is now running at over 2 million a week, which is what we were promised. And so we can anticipate a very significant rollout of vaccination. And in time, of course, this has to mean a very good prognosis for the development of the management of this disease. But I do want to leave with that note of complete suppression strategy. We still need a strategy to see that we eliminate the disease from the United Kingdom, and vaccination is not the end of it at all. It is one leg of the process, as we've heard earlier on. So we really need to come back and look at the test, trace, isolate and support system. And we would really like the government to learn the lesson from the vaccination program, which has been run through the public health service system, through the National Health Service and the general practice system of the UK, and look how successful it's been. We must compare that, I'm afraid, not well with the test, trace and isolate system that has been run through the private sector. The way to deal with this is to refund the public health system and switch it over. It's still not too late to do that. Thank you.
Thank you very much, Sir David. Thank you to everybody for the questions. Thank you very much to our special guests today for their clinical expertise, Dr. Alwan and Dr. Elkin. Thank you to everyone watching, whether that's live or catching up. Thank you to our amazing team of experts, all of whom are volunteers, sharing their expertise and listening to your concerns and questions. And we've really understood and seen the value of that listening in today's session. The new report on long COVID and all of the other reports that have been produced by Independent Sage over the months are available on the website, along with details of all of the scientists. Please do follow Independent Sage on Twitter if you don't already. We'll be back same time, same place next Friday. Stay home if you can. Stay safe. Keep well. Thank you, everyone.